This high-pitched, blowing, diastolic murmur, heard along the left sternal border, is typical of aortic regurgitation. Notice the decrescendo nature of this murmur. This murmur gets louder with an increase in afterload. Notice the change in this murmur with a hand grip maneuver. Rest. Hand grip. This murmur has a pitch similar to respiratory sounds and can be overlooked unless the clinician listens to the patient in held expiration. Notice how much easier it is to hear this murmur with held expiration. Breathing. Held expiration. Rupture of an aortic cusp can result in a cooing dove murmur. This type of murmur has a unique auditory signature. In severe aortic regurgitation, there may be early mitral valve closure, resulting in an Austin Flint murmur. Although similar to mitral stenosis, this murmur is introduced by a third heart sound, and the first heart sound may be normal or even diminished. Listen to an Austin Flint murmur. I will begin with normal sounds, then add the third sound, and finally the Austin Flint murmur. A systolic murmur is common in patients with moderate to severe aortic regurgitation. This murmur results from the large stroke volume ejected across the deformed aortic valve during systole. This murmur typically peaks in the first half of systole in the absence of significant aortic stenosis. I will begin with the diastolic murmur and then add the ejection murmur. In patients with both aortic stenosis and regurgitation, the systolic murmur usually peaks later in systole. I will begin with the systolic murmur of aortic stenosis and then add the diastolic murmur. If aortic regurgitation is heard to the right of the sternum, then aortic root pathology, such as an aortic aneurysm, should be suspected. Just before heart failure develops, patients with significant aortic regurgitation should have their valve replaced. Many cardiologists follow the 55 rule, recommending valve replacement when the left ventricular end systolic diameter reaches 55 millimeters or left ventricular ejection fraction falls below 55%. Aortic dissection can result in acute severe aortic regurgitation. In this situation, there is decreased forward stroke volume, resulting in pulmonary edema and sometimes cardiogenic shock. The arterial tree clamps down and prevents the wide pulse pressure normally seen in chronic aortic regurgitation. The absence of this common sign can make it challenging to diagnose acute severe aortic regurgitation. In summary, aortic regurgitation typically presents with a diastolic decrescendo murmur, which is heard along the left sternal border. Acute aortic regurgitation can occur as a result of trauma, endocarditis, or aortic dissection. Listen once again to the sound of severe aortic regurgitation.